To the Kanski lecture series, and this is the chapter 14, Acquired Macular Disorders. So let's get started. So, introduction. The macula is a round area at the posterior bone lying inside the temporal vascular arcades. It measures between 5 and 6 millimeter in diameter and subserves the central 15 to 20 degree of the visual field. So basically, macula is not the area. It's not the. It's called the fovea. The macula is all area which is lying around the temporal vascular arcade, and it is almost 5 to 6 millimeter diameter and almost serves the 20 degree of the visual field. Histologically, it shows more than one layer of ganglion cell in contrast to the single ganglion cell layer of the peripheral retina. The inner layers of the macula contain the yellow xanthophyll carotenoid pigment lutein and zeaxanthine in a far higher concentration than the peripheral retina. Hence the full name macula lutea yellow plaque. So basically, the macula contains more than one layer of a ganglion cells, and the inner layer of the macula contains is a yellow xanthophyll pigment, carotenoid pigment, lutein and zeaxanthine, and that is why it is known as a macula lutea yellow plaque. So the fovea is the depression in the retinal surface at the center of the macula with the diameter of about 1.5 millimeter, about the same as the optic disc. So basically the fovea is the area which is basically in the center of the macula, and it is almost the same size as that of the disc. Then there is a foveola, forms the central floor of the fovea and has a diameter of 0.35. It is the thinnest part of the retina and is devoid of the ganglion cell, consisting only of the high density of the cone photoreceptor and the nuclei together with their molar muscle. So between inside the fovea there is a foveola. So this is fovea. There is a foveola which is about 0.35 micrometer, and it is the thinnest part, and it is devoid of any ganglion cell, and it just contain the cone receptors and their nuclei. Then there is a umbu, is the depression in the very center of the foveola seen, which corresponded to the foveolar light reflex, loss of which may be an early sign of the damage. Then there is a foveolar avascular zone. It's a central area containing no blood vessels but surrounded by the continuous network of capillaries, and it is located within the fovea and extend beyond the foveola. The exact diameter varies with age and decrease. Its limit can be determined with accuracy only by the fluorescent angiography, average 0.6 millimeter. So that is why on the fluorescent angiography this area appears black. So basically this is a fovea. Inside is the foveola, which is about 0.35, and between them is a foveolar avascular zone. So these are the figures. A is showing us a normal anatomical landmarks. A is normal foveola, almost punctate central reflex, and a macular light reflex, band-like reflex encircling the fovea. This is a fluorescent angiography. Fovea yellow circle. Approximate extent of the foveal vascular zone is red circle, and foveola is a lilac circle. Central umbu is a white spot. So this is a fovea. So this is a fovea. This is a this is a fovea. This is a foveal avascular zone. This is a fovea. This is foveola, and this is umbu, this white central dot. Next is a retinal pigment epithelium structure. So the retinal pigment epithelium is composed of a single layer of the cells that are hexagonal in cross section. The cell consists of the outer non-pigmented basal element containing the nucleus and an inner pigmented apical section containing the abundant melanosome. So you know that retinal pigment epithelium basically consists of the single layer of the cells, and it has a non-pigmented basal element, outer non-pigmented basal element, and inner pigmented apical section which contain the abundant melanosome. Next is the cell base is in contact with the Brooks membrane, and at the cell apex Multiple thread-like villus process extend between the outer segment of the photoreceptor. So basically, its outer segment is in contact with the Bruch's membrane, and the inner segment is in contact with the outer segment of the photoreceptor. At the posterior pole, particularly at fovea, RP cells are taller and thinner and more regular in shape and contain more numerous and larger melanosome than in periphery. So it is very important for the fluorescent angiographic point of view. The RP is taller here, and they are more regular and contain large number of melanosomes. So what are the function of the RPE? RPE cells and the intervening tight junctional complexes zona occludens constitute the outer blood retinal barrier, preventing extracellular fluid leaking into the subretinal space from the choriocapillaries and actively pumping ions and water out of the subretinal space. So first is that it provides the blood retinal barrier. So between the RPE cells, there is a tight junction, which is known as a zona occludens, and it constitutes the outer blood retinal barrier. And what its function is, it basically prevents leaking of the subretinal into the subretinal space from the choriocapillaries, and it secretes the ions and water out of the subretinal space. Its integrity and that of a Bruch membrane is important for the continued adhesion between the two, thought to be due to the combination of the osmotic and hydrostatic forces, possibly with the aid of the hemidesmosole attachment. So basically, if this is intact, the RPE is intact, it can lead to it is important for the adhesion of these two, because if there is some disruption, it can lead to the detachment of the retinal pigment epithelium. Facilitation of the photoreceptor turnover via phagocytosis and lysosomal degranulation of the outer segment following shedding. So it also phagocytosed and lysosomal degeneration of the outer segment of the photoreceptor. So whatever when the photoreceptors shed their outer segment, these are being phagocytosed by the RPE cells. Preservation of an optimal retinal milieu, maintenance of the outer blood retinal barrier is a key factor, as are the inward transport of the metabolite, mainly small molecules such as amino acid and glucose, and the outward transport of the metabolic waste product. Storage, metabolism, and transport of vitamin A in the visual cycle. The dense RPE pigment serve to absorb the stray light. So whenever there is a pigment epithelium, it also absorbs the any kind of the stray light. So next is a Bruch membrane, which lies outer to the RPE. So the Bruch membrane separates the RPE from the choriocapillaries, and on the electron microscopy consists of the 5 distinct elements. It contains of the basal lamina of the RPE, the inner collagenous layer, a thicker band of the elastic fibers, outer collagenous layer, and the basal lamina of the inner layers of the choriocapillaries. So you know that before Bruch membrane, outer part consists of the choriocapillaries and the inner part consists of the RPE. So basal first layer is the basal lamina of the RPE. Then there is an inner collagenous layer. Then there is an outer. There is an elastic fiber layer. Then there is an outer collagenous layer, and then there is an inner basal lamina of the inner layer of the choriocapillaries. The RPE utilizes Bruch membrane as a route for transport of the metabolic waste product out of the retinal environment. Changes in its structure are thought to be important in the pathogenesis of many macular disorders. For example, intact Bruch membranes may be important in the suppression of the choroidal neovascularization. So how will you so this is a figure which is showing us the layer of the retinas. It is showing us so this is Bruch membrane, then there is an RPE, then there is a photoreceptor layer, then there is an outer nuclear layer, then there is an external limiting membrane, then there is an outer plexiform layer, then there is an inner nuclear layer, inner plexiform layer, nerve fiber, ganglion cell layer, and the nerve fiber layer. So this is how it goes, and then there is an internal limiting membrane. Next is how to clinically evaluate of the macular disease. So symptoms include blurred vision and difficulty with close work as an early symptoms. Onset can be rapid in some conditions such as CNV. So basically, when there can be decrease in visual acuity. So there is a two things known as positive scotoma and a negative scotoma. So the positive scotoma, in which the patient complains of something obstructing central vision, is a symptom of a more severe disease. This is in contrast to optic neuropathy, which typically causes a missing area in the visual field, which is a negative scotoma. So whenever there is something missing in the central field, it is known as positive scotoma. But if something is missing in the peripheral field, it is known as a negative scotoma. Then there is a metamorphosia, which basically mean that there is a distortion of the images. Distortion of the perceived image is a common symptom that does not occur in optic neuropathy. Micropsia, decrease in vision image size, is caused by spreading a part of the foveal cone and is uncommon. Macropsia, increase in image sizes due to crowding together of the foveal cone, and it is uncommon. Color discrimination may be disturbed, but is generally less evident than in even relatively mild optic neuropathy. Difficulties related to dark adaptation, such as poor vision in dim light and persistence of after image, may occur. Metamorphosia is a common early symptoms of a macular disease and can be ameliorated with the Amsler grid. So how will you investigate the cases of the macular diseases? So very important investigation is the fundus fluorescent angiography. So fundus fluorescent angiography is basically an investigation technique in which we inject fluorescein into the body. So when it reaches the retinal blood vessels, so what happen is that it basically illuminate any area of leakage, if there is a leakage from the blood vessels or any area of pooling, and we detect it by imaging the retina. So fluorescein in the blood has a property. So what is property is that is basically absorb the light of the blue filter, which is about 490 micrometer, and emits light of a green wavelength, which is of 530 micrometer. So whenever this get a green light is basically being so in a case of a fluorescent angiography, we put the blue excitation filter, we put on the blue light to the fluorescein, and when the fluorescein emit the green light, it is being captured by the camera, and we can say that we can see any of the blood flowing uh, from the retinal blood vessels as well. And it will get us the imaging of the retinal vessels and sometimes choroidal vessels as well, and we can identify any area of leakage, any new vessels, and other findings as well. So fundus fluorescent angiography introduction. Fundus fluorescent angiography should be performed only if the findings are likely to influence management. So fluorescence is the property of the certain molecule to emit a light of a longer wavelength when stimulated by the light of a shorter wavelength. The excitation peak for fluorescence is about 490 nanometer. In the blue part of the spectrum, the wavelength of the maximum absorption of the light energy by fluorescein stimulated molecule will emit the yellow green light of about 530 nanometer. So basically fluorescence is a property of any material. So when it is excited by some kind of a short wavelength, it will emit the wavelength of a longer wavelength. Like if you excite the fluorescent with the blue light, whose wavelength is about 490 nanometer, it will emit the light of a green yellow light, which is about 530 nanometer. Then fluorescent sodium is basically the molecule which has such property. Sodium fluorescent is an orange water soluble dye that when injected intravenously remain largely intravascular, greater than 70% of bound to the serum protein. It is excreted in urine over about for 24 to 36 hours. So basically uh, fluorescein is remain usually intravascularly, so that is why we can identify the passage of the blood, and we can track the retinal blood vessels. Fluorescent angiography involves the photographic surveillance of the passage of the fluorescein through the retinal and choroidal circulation following intravenous injection. So there is very important thing. So there is an outer blood retinal barrier and an inner blood retinal barrier. The outer blood retinal barrier, the major choroidal vessels are impermeable to um, both bound and free fluorescence. However, the walls of the choriocapillaries contain fenestration through which the unbound molecules escape into the extravascular space, crossing Brooks membrane, but on reaching the RPE are blocked by the intercellular complexes termed as tight junctions or zona occludens. So what happens is, that we have two types of a blood retinal barrier. First is the between the RPE cells, there are zona occludens which are giving us a outer blood retinal barrier. So what happens is, because the the choroidal vessels, the major choroidal vessels are basically impermeable to a fluorescent molecule, both unbound and bound. But when it reaches through the choriocapillaries, there is a leakage of the fluorescence, unbound fluorescence, and but at when it comes at the RPE, it cannot cross it because there are a blood retinal barrier. So that is why when we inject a fluorescent in the body, first there is a leakage in the choriocapillaries. That is why the choroid becoming slightly white in color. Inner blood retinal barrier is composed principally of the tight junction between the retinal capillary endothelial cells, across which neither the bound nor free fluorescence can pass. The basement membrane and pericyte play only a minor role in this regard. Disruption of the inner blood retinal barrier permits the leakage of both bound and the free fluorescein into the extravascular space. So next is basically the inner blood retinal barrier, which is basically formed by the retinal capillaries, and because the tight junction between the endothelial cells, it will not allow any bound or unbound fluorescein to get leaked, and so that is why the fluorescence remain intravascular except if there is any kind of disruption in the case of the retinal vessels. So you can see that excitation of the emission of fluorescence, so excitation is 490 nanometer and emission is at 530 nanometer. So then the filters are being placed. So cobalt blue excitation filter, incident white light from the camera is filtered into the, so that a blue light enters the eye, exciting the fluorescent molecule in the retinal and choroidal circulation. So what happens is that there is an excitation filter and then there is a barrier filter. So when the white light passes through this excitation blue filter, it will convert all the white light into the blue light, and when it incident at the fluorescent, it will emit the green light. So in the cases of the yellow green barrier filter blocks any blue light reflected from the light, allowing only the yellow green emitted light to pass. So yellow green filter will block any blue light that will be reflected, and will and the yellow green light will be only allow it, this will pass. So this is an outer blood retinal barrier. So there is a zona occludens, and this is forming the basically the blood retinal barrier, and this is an inner blood retinal barrier. A is showing intact and B is showing a disrupted. So this is a principle of fluorescent angiography. So this is a white light. When it is passes through the blue excitation filter, it is converted into blue light after striking it. So some will reflect the blue light and some will reflect the yellow light, green light, but only the yellow green light will be passing through. Next is an image capture. After that there is an image capture. So image capture in a modern digital camera uses a charge coupled devices. Digital imaging permits immediate picture availability, easy storage and access, image manipulation and enhancement. Modern devices also typically require a lower concentration of injected fluorescein to obtain a high quality image with corresponding substantially lower incidence of an adverse effect. So there is some contraindication to fluorescent. Fluorescent allergy is an absolute contraindication, and a history of a severe reaction to any allergen is a strong relative contraindication. Preventive anti-allergic pre-treatment may be useful in some cases. So sometimes allergic reaction can also occur with fluorescein angiography. So if there is a fluorescein allergy, it is an absolute contraindication for the fluorescein angiography. Other relative contraindication include renal failure. Lower fluorescein dose is used because in a case it is excreted through urine. Pregnancy, moderate severe asthma, and significant cardiac disease. Allergy to iodine containing media or seafood is not a clear indication to fluorescein angiography or to a indocyanine green angiography. Next is a technique. Facilities must be in place to address the possible adverse event. This include adequate staffing and a resuscitation trolley that include drugs for the treatment of anaphylaxis, a couch or recycling chair, and a receiver in a case of vomiting. Significant nausea and vomiting are less common using a lower fluorescein concentration required by the moderate digital camera. So basically you must have all things in prepared for any kind of reaction. So most of the common adverse effect is that there can be the nausea and vomiting, so you should be prepared to deal with that as well. And if so the nausea and vomiting now are less common using a lower fluorescent dose. Adequate pharmacological matrices is important to obtain a high quality imaging. Media opacity such as cataract may reduce picture quality. So first you have to dilate the pupil so that we can capture all of the fundus. The procedure is explained and the formal consent is taken. It is important to mention common and serious adverse effect, particularly the inevitable skin and urine staining. So fluorescein can also stain the urine. So these are the adverse effect in the fluorescein angiography. So there is a discoloration of the urine, skin and urine, which is invariable. There can be extravasation of the injected dye, giving a painful local reaction. Treat with cold compresses. So if you give in the skin, the fluorescein angiography, it can cause a painful local reaction, which is treated with the cold compression. Nausea and vomiting now rare with the lower concentration of a fluorescein. There can be itching and rash, sneezing and wheezing. There can be vasovagal episode or syncope, usually due to anxiety, but sometimes due to ischemic heart disease. Anaphylactic and anaphylactoid reaction 1 in 2000 angiogram. Myocardial infarction extremely rare. Death can also occur 1 in 2,20,000 in larger study. Next is the patient should be seated comfortably in front of the fundus camera and color photographs. Red, green incident light to enhance the red detail, and autofluorescence images taken as indicated. So first you can just take the red free images, or you can also take the autofluorescent images before commencing the fluorescein angiography. An intravenous cannula is inserted. A standard cannula is often preferred because rather than a less secure butterfly wing infusion. After cannulation, the line should be flushed with a normal saline to check patency and exclude extravasation. Fluorescein, usually 5 ml of a 10% solution, is withdrawn in the syringe and ejected over the course of a 5 to 10 seconds, taking care not to rupture the cannulated vein. So you take almost 5 ml of the 10% solution. Oral administration, you give it in within 10 to 5 to 10 seconds. Oral administration of a dose of a 30 milligram per kg is an alternative of if the venous access cannot be obtained or is refused. A 5 ml vial of a 10% 100 milligram fluorescein contain the 500 milligram, and picture should be taken over 20 to 60 minutes forming ingestion. So basically a 10% solution contain means that 1 ml is basically 100 milligram. So 5 ml means that there is a 500 milligram of dose that we are injecting. Images are taken 1 to 2 second interval initially to capture the critical early transient phase. So because the early transient phase is very fast, like choroidal vessels are filling very fast, then arterial vessels are filling very fast, so you must capture it very early, and there is a lower interval like 1 to 2 seconds between the images. Then after beginning 5 to 6 seconds after injection, tapering frequently through subsequent phase. With monocular pathology, Control pictures of the opposite eye should be taken usually after the initial transit phase has been photographed in the index eye. If appropriate, image may be captured as late as 10 to 20 minutes. Stereo images may be helpful to demonstrate elevation and are usually taken by manually repositioning the camera sideways or by using a special device, a stereo separator, to adjust the image. They are actually pseudo stereo image, as true stereo requires stimulation a simultaneous image capture from the different angle. So basically you take a picture as fast as you can, then you take it almost for 10 to 20 minutes. So you can see here there is an injection of the fluorescein in the body, and B is showing the circulation of the fluorescein. So you can say within a 10-second the fluorescein reaches up to the eye. So that's it for the part 1. See you in the next lecture.